Hi, welcome to part 2 of my series on Neoplasia. In the previous chapter, we discussed the basic fundamentals of Neoplasia. Now, we shall move on to what triggers these changes, how it changes, and how it spreads. So first off, let's start with carcinoma in situ. Carcinoma in situ. It's basically a pre-invasive epithelial neoplasm, which shows all the cytological features of malignancies and involves the entire thickness of epithelium and it remains confined within the epithelial basement membrane. Alright? So now, tumor cells cannot reach the potential routes of metastasis, such as the blood or lymphatics, until the basement membrane is breached. Alright? And remember this. It will always evolve from a pre-invasive stage. Alright? Let me repeat this one more time. It evolves from a pre-invasive stage. It's a pre-invasive epithelial neoplasm. It shows all cytological features of malignancy. It involves the entire thickness of the epithelium and remains confined within the basement membrane. It will remain confined within the basement membrane of the epithelium until the basement membrane gets breached. Now, moving on to dysplasia. It's very similar to carcinoma in situ and often can be confused between two. Alright? It's a disordered growth which is reversible and it shows all cytological features of malignancy, such as in carcinoma in situ. Again, entire epithelium is involved and there is an intact basement membrane. Now, these features are in common with carcinoma in situ. However, the cellular changes are a lot more prominent, such as cellular pleomorphism, the large hyperchromatic nuclei, high nuclear to cytoplasmic ratio, loss of polarity. Alright? Now, there's some subtle differences. For example, I mentioned that there's a reversible growth. So now, once you take away the stimulus which is causing this change, it will immediately revert back to normal. Not with carcinoma in situ. It's already formed a carcinoma. It's just confined, that's all. Here it's not just confined, it's still in its evolution stage. However, it can revert back to normal. Alright? Now, it can be classified as mild, moderate, and severe depending on the thickness of the epithelium. Now, let's draw it out for you. Suppose you have layers of epithelium under each case. Now, in the case of mild, you find only the most superficial layer being involved. Whereas with moderate, you find almost half the layer being involved. Whereas with severe, you find more than 3/4, almost the entire epithelium being involved. Alright? So mild, just superficial part. Moderate, it's about half. Severe is about 3/4 to the entire epithelium being involved. Alright? So it depends on thickness of the epithelium being involved. Now, what can potentially happen to this dysplasia? For starters, if it's mild or moderate dysplastic changes, so if the entire thickness is not involved and you remove the cause, then it's reversible. Ergo, no cancer. However, if it's a serious form of dysplasia which involves the entire epithelium, now if the entire epithelium is involved, it's closer to the basement membrane. Hence, it can breach the basement membrane. That makes it invasive. That's how cancer can break out from the epithelium. Alright? Now, moving on to metastasis. This is probably one of the most important parts to understand about malignancy. Alright? So now, metastasis is when tumor deposits, which are discontinuous with the primary tumor, are located in different tissues around the body. Let me repeat that one more time. Tumor deposits, which are discontinuous with the primary tumor, located in different tissues around the body. And the secondary deposits are known as metastases. That's with an E instead of an I, as you would normally spell metastasis. Alright? Now, what's significance of metastasis? First of all, it's the first important criteria for malignancy. However, there are two exceptions. Gliomas, seen in the central nervous system, and basal cell carcinoma. These are invasive, except they're not malignant. It's very difficult for it to detach and metastasize. All right? Now, once metastasis occurs, there's a decreased possibility of cure for the cancer. All right? Since it's so widespread, it's very difficult to administer radiation therapy or chemotherapy or even to surgically operate on it, because it's very difficult to find all the foci of the cancer cells. And metastatic spread is probably the most common cause of cancer death, because once you find cancer cells replacing normal cells all over the body and so many vital functions being compromised, that's when overall death can potentially take place. All right. Now, the morphology of these metastases, they closely resemble the primary tumor. However, the cells are highly anaplastic. The origin can't be made out so easily because of the poor differentiation. Because of poorly differentiated cells, you cannot tell where the exact site of origin of the primary tumor really is. All right. Now, sometimes you find unknown primaries, where metastases appear without any clinically detectable primary tumor. Suddenly, on a scan or suddenly on palpation of, say, a swelling, you find tumors, which on biopsy or further examination you realize is not native to that tissue or any surrounding tissue. It's from another place, whereas you don't find any signs or symptoms of manifestations from that original site where the primary tumor is located. All right. Now, moving on to the pathways of spread. This is probably the most important part of metastasis. The most common form of pathways of being spread is through the lymphatic channels. All right. It's the most common route. Now, typically, cancer cells can invade the closest lymph node. This is also the regional lymph node. It's also called the sentinel lymph node. It's the first node in regional lymphatic drainage that receives the lymph flow from the primary tumor. All right. It's the first lymph node which receives the lymph flow from the primary tumor. Now, the pattern of lymph node involvement, to detect this, you have to follow the natural route of lymphatic drainage. This is why it's important to understand the pathways of lymphatic drainage. That way you can trace out the pathway of spread of metastasis of the cancer. All right. Now, sometimes you find something called a skip metastasis, where the local lymph node is bypassed and lymphatic metastases develop in lymph nodes distant from the primary tumor. For example, carcinoma of stomach or carcinoma of testis can be manifested in lymphadenopathy of the left supraclavicular lymph node. Right? So it's also known as Virchow's node, and it's pathognomic in tuberculosis, which is not important in this case, carcinoma of stomach, and carcinoma of testis. All right? And as you know, supraclavicular lymph node is nowhere close to the stomach or the tumor of the testis. So clearly, it's bypassing all the regional lymph nodes and it's manifesting all the way up in the supraclavicular region. All right? Sometimes you find retrograde metastasis, where tumors spread against the flow of lymphatics. For example, carcinoma prostate can manifest in the supraclavicular lymph node. Now, to put this in better terms, sometimes when you're driving down a road and you find a one-way, you're following the one-way, you'll always find that one guy who decides to come in the opposite direction, right? He comes in the opposite direction from one-way. Think of that guy as retrograde metastasis. He's going in the exact opposite of flow of traffic. In this case, we're calling it lymph. All right? Now, on microscopic examination, you find that tumor cells deposited in marginal sinus of lymph nodes. But later, they extend throughout the entire node. All right? Now, probably if you remember from histology, suppose this is the lymph node. You find the follicles, you find the cortex, this is all, and this is the capsule, and there's a subcapsular space. First invades in that space, all right, thickens all around, and eventually it extends inwards towards the cortex. All right. Now, what's the significance of these metastases? They're of prognostic value. For example, suppose it's carcinoma of breast. You have to examine the axillary lymph nodes because that's when you have a true idea of the spread of the cancer. And that's when you can actually stage the cancer. We shall get to that later. All right. Now, the second most important pathway of spread is hematogenous spread. All right. This is most commonly seen with sarcomas, that's cancers of connective tissues, instead of carcinomas. Carcinomas is more to do with internal structures such as organs. So now, some cancers which commonly prefer hematogenous spread includes osteosarcoma, choriocarcinoma, and renal cell carcinoma. All right, they just love hematogenous spread. They love spreading through the circulatory system. All right. So typically tumors with affinity for venous invasion includes hepatocellular carcinoma and renal cell carcinoma. Now with hepatocellular carcinoma, it may invade branches of portal and hepatic veins and grow within the main hepatic channels, right? Whereas with renal cell carcinoma, you find that the renal cell carcinoma, it extends out through the renal vein and snakes its way up the inferior vena cava and can reach the right side of heart, all right? So from here, the kidney, it goes all the way through the renal vein, then the inferior vena cava, and then reaches the right side of heart. All right. And sometimes you find a pattern of involvement. So the metastases generally follow the route of venous flow. Now you may notice I commonly say venous flow instead of arterial flow. And that's probably because in my previous segment I mentioned that cancer cells do not invade the elastic coverings around arteries because it's really tough, so it makes it more resistant against invading metastatic cells. So they prefer the wide porous veins. Now the most common target organs, what do you think that would be? Actually, it's lungs and the liver, followed by brain and bones. Now lungs, because most systemic circulation passes through the lungs, so it's easy to get deposited there. Whereas with liver, it's because of portal circulation. So it just ends up in the liver through portal circulation. And you can also find it in the brain. Now, there's also bone metastasis, all right? So now, bone metastasis. On radiographic appearance, you find that there are osteolytic lesions, which are seen as radiolucencies. So they all commonly appear as pathological fractures or hypercalcemia, so it appears more dense. And there's osteoblastic lesions, where there's radiodensities. This is often because of increased serum alkaline phosphatase. There's reactive bone formation. All right. So you find target organs which often directly metastasize to the bone. That includes the thyroid gland, the kidney, the intestine, the liver, the breast, prostate, and lungs. They metastasize to the bone. Now, bone metastases, they often end up in the vertebrae, the vertebral column, because they spread through the paravertebral plexus. Sometimes even carcinoma thyroid and prostate can also, through the paravertebral plexus, spread to the spinal cord. It's a common site of secondary metastasis in carcinoma of thyroid and carcinoma of prostate. All right. Now, some organs in general tend to be resistant to hematogenous spread. What are they? The most common ones are the heart, spleen, and skeletal muscle. Why is this? Well, in case of the spleen, it's because of the high amount of sequestrations present in the spleen. So, and the trabecular meshwork, the trabecular pattern inside the spleen, it's so divided. It's very difficult for any cancer cell to get lodged in the spleen. Now, with the heart, it's because of the generally rich oxygen blood supply to the heart, to the myocardium. Similar thing can be said for skeletal muscles. Because of the rich oxygenated blood supply, you rarely find tumors in the heart and skeletal muscle. And you find that vessels, such as in case of arteries and arterioles, are relatively resistant because of the elastic intermass. And capillaries and venules are very easy to invade. All right. Now that was the hematogenous pathway. Then there's transcelomic pathway, which is often through body cavities. So malignant tumors which arise in organs adjacent to body cavities, such as in organs, they spread through the cavities, such as in case of ovaries, intestines, or lungs. They seed body cavities, and malignant cells exfoliate from organ surfaces and lodge in the body cavities, and this can be detected in cytological examination of fluid, where you find malignant cells. Right? So that's adjacent to body cavities. Sometimes they end up lodging directly in the body cavities, such as in peritoneal spaces, where you find ovarian tumors, or you find malignant GI tract tumors, which can often cause ascites because of obstruction. Sometimes they can lodge in the pleural cavity, causing pleural effusions. Lung tumors can generally cause this. They can cause pleural effusions. Sometimes you find them in the pericardial fluid, causing accumulation of pericardial fluid, or in subarachnoid spaces, such as in glioblastomas, which can often obstruct and cause CSF accumulation, or sometimes just in joint spaces. It's pretty rare though. And moving on to the fourth form of pathway spread, that's epithelial line spaces. So sometimes just across the epithelium itself, these tumor cells can make their way across and invade neighboring structures. For example, you might find tumors cells from kidneys going all the way down the ureter till the bladder and depositing there. Or sometimes you just find tumor cells from the ovary. They enter through the fallopian tubes and make its way down to possibly the uterus. All right, this is how they can potentially spread. And then there's direct transplantation. Now, this is only theoretical, so it can be theoretically proven with surgical instruments. However, there have been no documented cases of direct transplantation as a mode of spread of cancer cells. All right. Now, moving on to the invasion metastatic cascade. You find invasion of the extracellular matrix. Let me explain with this diagram over here. Here you have normal epithelial cells, all right? You find that the cells have proper orientation with each other. They're adhered to the basement membrane, which is intact, and they show normal cell function. That is a normal nuclear to cytoplasmic ratio. There's normal cell size and normal cell structure. The receptors which are connecting between the cells and the basement membrane, and this E-cadherin which acts as a bond between these cells, holding them together. Then you find formation of malignant cells, so eventually a malignant tumor, and this is largely because of the anaplastic changes you find. For example, hyperchromatic nuclei, you notice that the nucleus is slowly getting bigger, and the nuclear cytoplasmic ratio is changing, also because of cellular pleomorphism. Then eventually the E-cadherin bonds, which you see here, which is still intact over here, it just breaks away. So as a result, there's an overall loosening of cellular junction. So there's loosening of tumor cells due to loss of E-cadherin fibers. See, these guys over here, all loose. They can break apart anytime they want. Now, there's eventual degradation of the basement membrane. It happens locally because of increased activity of collagenase from these cells. Then there's attachment of tumor cells to extracellular matrix proteins. See, you find these tumor cells, which just recently arose, they slip in their receptors down to ECM proteins and they attach themselves. So there's now formation of new sites in the extracellular matrix for attachment of tumor cells. And then there's eventual migration of tumor cells through the degraded extracellular matrix. These cells, tumor cells, form their own autocrine motility factor, or they can slip away. They breach through and they slip away through the degraded extracellular matrix, and then they migrate through a near-ring tunnel. And now looking at metastasis, for example, in the blood. Here you have a primary tumor. There's invasion of the basement membrane involved by tumor cells. Then it makes its way down to the closest blood vessel by destroying tissue along the way, mostly basement membranes, and it squeezes in through the vessels by a process called intravasation. Then, once it's in circulation, it interacts with the host lymphoid cells. Now, the host lymphocytes, they try the best to react to this foreign body. So, what does it do? Causes them to clump together. However, this clumping causes formation of a tumor embolus, right? So now this tumor embolus is going to drift around as much as it wants and then cause extravasation of tumor cells at the metastatic site. So here, intravasation is where it gets in, extravasation is where it gets out. So that causes metastasis in a nutshell. However, this new metastatic tumor causes angiogenesis by secreting growth factors. So there's eventual tissue destruction in the neighboring tissues. However, there's increased capillary formation to the tumors, causing increased blood supply. This is how the metastatic tumor eventually grows.